Hello, we are the Association for Child and Adolescent Mental Health, or ACAM for short.
Thank you very much, and thank you for inviting me to be here. And it's been an amazing day so far. We've certainly heard a lot and learnt a lot. From hearing about the neurobiology and epidemiology and assessments of risk and so on, let's think a little bit about how to help these young people clinically, because that's sort of what you all do. That's why we're all here. And I always feel uncomfortable when people refer to me as well-known and et cetera, because actually I just try my best. I'm just an ordinary person trying my best, just like all of you. So if we just try our best by trying to understand young people this afternoon together, that'll be good. So this is actually what a young person told me one day. And she didn't make it, that wasn't a joke. Yeah, that she actually really meant that. She said that almost in tears. I wanted to kill myself, but then I was worried it would ruin my makeup. So what's happening there? What's happening with that statement? You see, it's a bit like, I'll just try and demonstrate it with my hand. Too many things to hold. If you imagine this is somebody's mind, then there's a pocket in the mind here where that suicidal feeling sits, of I really want to kill myself. And then there's another pocket of I also want to have a life, I want to look good, and I care about my life, and I have some hope. You see what I mean? That's what this statement is saying. But the two are completely disconnected from one another. The good part doesn't help the bad part to feel any better. When she's in the bad part, that's all she feels. It's a bit like if you step into that zone where the negativity is in the mind, that's all that is there. You have no view over the other part that has a different feeling. I can illustrate it a little bit more with a comment from another patient who not too long ago told me this. There are 3 of me, I feel a bit crazy. Now this patient doesn't have multiple personalities. She's just describing 3 aspects of herself. So the one is angry, anxious, doesn't want to eat, wants to punish me and hates me. That one doesn't want to be with people and doesn't trust people. That one doesn't care about me or what she does to me. So she's describing this pocket of the bad feeling, isn't she? And actually she's describing really, really well. The other me is happy, confident, enjoys people and feels good about myself. And then there's a bit of me in the middle that feels confused. Now, when she's in one pocket, she feels just that one thing. And in another pocket, she feels the other thing, and she flips between these states. And when she gets into the pocket of having the negative bad feelings, it's like a very, very fast whirlpool that sucks her down into feeling more and more negative, and it often results in her cutting herself, or a couple of times taking overdoses. So what makes her switch from one side to another, or what makes her lose the perspective of having a view over both sides? This is what she told me one day. I woke up feeling good and okay. Then I went to school and I heard that my boyfriend were hanging out with other friends at school. He didn't call me the boyfriend goes to another school. He didn't call me as he usually does, so I thought he was enjoying their company more than mine. They have more to offer than me. I am trouble. I thought he wouldn't want to be with me and that I would lose him. That felt unbearable. So I contacted him and I ended the relationship. I hated myself and I felt hated by him. I wanted to cut, but I couldn't because I was at school. Over the course of the day I felt worse, and then I got home and I cut myself and I felt better. Now let's just mentalize a little bit what she's saying to us. Let's imagine there's her and there's the boy. What is in her mind? What is she feeling? What is going on in her mind? She felt an incredible sense of anxiety. Yeah? She didn't hear from him and she felt very anxious and very worried that he's not going to want her. And that immediately triggered a feeling in her of hating herself. And then she started to imagine his mind. And what did she think was in his mind? He hates me. So she phoned him up and ended the relationship. So can you see how quickly it goes from an anxiety feeling to immediately moving on to feeling incredibly bad about herself and feeling he has left her, he doesn't want her anymore, and then moving to he actually hates me, so I therefore hate him and I cut him off. So it goes through absolute milliseconds. And then of course you can see how the self-harm happens. So with that sort of introduction, what is mentalization? Can I see a hands up of people who knows what it is? Because otherwise then I'm not going to spend a lot of time explaining it. Who is aware of the concept? Okay, I'm sorry guys, you're in the minority. So you're going to have to put up with me giving a tiny bit of an explanation of what mentalization is, with the emphasis on the word tiny. So this is John Allen's definition. I actually quite like it. It's a bit wordy, but it makes behavior understandable. It helps us to understand ourselves, and it makes us sensitive to other people. That's it in a nutshell. Can you see how important that is, therefore, in relationships, in making sense of the world, in making sense of ourselves? The talk this morning about pain and the threshold of pain and people with borderline not experiencing pain. Perhaps one of the keys can also be, if they are more in touch with themselves, actually they might be more able to experience the sense of pain that is happening within them. You see what I mean? So, and not only does this help one to be in touch with yourself, but it also helps you to be sensitive to other people, and it helps you to make sense of behavior of other people. So in a way, people say, what's the difference between mentalization and mindfulness? So mindfulness is where you become aware of yourself, your inner state. Mentalization is very similar. You become aware of what's going on inside yourself. You become aware of what you feel. You become aware of, I'm angry, I need to just take a deep breath, think before I speak, that kind of thing. Yeah, that's mentalization. People ask, what's the difference between mentalization and empathy? Empathy is putting yourself in the shoes of somebody else and seeing something from their perspective. Mentalization is that as well. And mentalization is seeing your role in how other people feel. So it's both helping you to tune into yourself, helping you to be sensitive to other people, and helping you to see how what you do and say makes them feel and say and behave, etc. So it looks a little bit like this. If I feel like this, I do that, and if I do that, it makes you feel like that, and when you do that, it makes me feel like this, and etc. So that is a sort of a nutshell explanation. Now let's put you to the test. In terms of mentalization, many of you that have seen me present before would be familiar with this clip.
See this? Oh no! Hey, you loser moron! Look where you threw it! Now go and get the ball, come on! Hey, did you hear what I said? Don't you get it? What are you looking at, huh? What are you looking at? I said go get the ball! You can't understand me or something? You moron! Go get the ball, right now! What are you looking at, huh? What are you looking at? I told you to get the ball, right? Now you hear me or what? Stop staring, okay? Go get the ball! Go get the ball!
why did the boy kick the pots? Let's mentalize. What was going on for him? Why did he kick the pots? Any ideas? Frustration, yeah, absolutely. What else? Excess adrenaline, yeah. What else? Sorry, say that again? To block the path in case the boys chase him, yeah, that's a possibility. He's humiliated, yeah. To have control, yeah.
Could have been the boy's house.
Could have been the boy's house. It happened to have been the boy's house, yeah. So, I mean, all of you are right with what you say, but you see, it's a bit like this. So, emotions is a bit like the layers of an onion. Sorry, this is going to be difficult with. So, it's a bit like anger is sort of the top emotion, because we can see he's doing something in anger, but you can peel the layers off. And underneath the anger, we can see the humiliation, we can see the shame, maybe he feels unloved, unwanted, attacked, scared, nervous. So as you peel the layers off, you expose more feelings underneath the layers. Now what you have just done is mentalization. That's mentalization in a nutshell. It's trying to be curious about the mental state of somebody else. It's trying to look at somebody's behavior and wonder what is the person feeling underneath the behavior. When we do training events for parents and teach mentalization, it's a whole day workshop that I do. But my take-home message, and if parents just take one thing home from the whole day, I want that thing to be, when people do things, they do things because of feelings they have inside them. So if it can ignite a tiny bit of curiosity in parents about what is he feeling when he does that, that would slow down assumptions. Because when people make assumptions, he's doing it because he's naughty, he's doing it because he wants to make me feel bad, he's doing it to challenge me. You see, all of those things are assumptions people make about somebody else's state of mind. It's not curious about what are you feeling, what's happening for you. Do you see what I mean? So that's the difference between mentalization and non-mentalization. So when we mentalize, we are curious about mental states. We are aware of our impact on other people. We are also aware that mental states are opaque. I can't tell you what you are feeling. I can't tell my patients what they are feeling because it's opaque. I can wonder, I can ask, I can inquire, but I can't say, you feel this or you feel that. When one mentalizes, you allow for different perspectives. Very often when one doesn't mentalize, you're very quick to feel paranoid. I mean, that's just a very brief introduction for people on what mentalization is. That clip that I showed, actually just after that clip, the film shows a very good clip that I also often show in teaching, but because of time constraints, I don't have time for that. But where the boy's mum, whose pots it was, accuses this boy's dad of not being able to control his child. And then he gets so cross with the boy that he slaps him through the face. And he calls the boy naughty and all sorts. So it sort of shows a parent who is overwhelmed with his own emotions of embarrassment and shame. And you see this, I'm going to need my arms here. So this is the other thing. In mentalization, for us to be able to see somebody else's perspective, for us to be able to be curious about what goes on into somebody else's mind, we need to be able to see the person. But if we get emotionally completely overwhelmed with a strong emotion, so in that case the dad being completely emotionally overwhelmed with his sense of humiliation and shame, it's a bit like it does that. It blocks your eyes. And then all you can see is your own feeling of shame. And then one easily makes an assumption to think, you did this to me deliberately. You see what I mean? But if one can open the shutters where you're not overwhelmed by your own feelings, you can make space to think about, I feel overwhelmed now. I feel really attacked by this woman. I feel like bad dad, putting myself in the dad's shoes. but what happened for my son? Why did he do that? Why did he kick the pots? What was going on for him? That's a mentalizing stance, where you're aware of your own feelings and you remain curious about the mental state of somebody else. Okay, does that sort of make sense? Very good, well done, congratulations. That was the quickest introduction, so you're doing very well this time of the afternoon. I'm just going to say a couple of words about some research with borderline adolescents and mentalization. Carla Shaw from America did research, and it's interesting, in her study, what she found is that borderline adolescents hypermentalize. That is the mentalizing error they make all the time. So it's not that it's more the hypermentalization that comes out very profoundly. So what is hypermentalization? You all hear about patients telling you they overthink. Yeah? I think of that as an example of hypermentalization. To give you an example of hypermentalization, a patient came into a session and said, I cut myself today, and the therapist said, well, what happened? The patient said, well, I don't know, I was at school and I just had a desire to cut myself, so I went to the toilet and I cut myself. And the therapist said, but what happened before you cut yourself? So the patient said, oh, nothing really, I just wanted to cut myself. You know, this happens to me, you know that. I just get a desire to cut myself, so I just went to the toilet and I cut myself. And the therapist said, well, let's just slow down. Let's just go back. If I was a fly on the wall, just before you had the desire to cut yourself, what would I have seen? What happened? Where were you? What was happening? Then the patient said, well, I was walking from the one lesson to the other lesson, and Mrs. A walked past me, and you know, I really like her, and we have a good relationship, so I greeted her, but she didn't greet me back. So then I know exactly what happened here. She's very good friends with the history teacher, and I didn't hand in my history homework. So the history teacher must have told her that I am lazy, and now she doesn't like me anymore, and I've lost her. Do you see what I mean? That is hypermentalization. There's a tiny thing that happens, and the patient goes boom, 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 and ascribes so many details to the story, and you can see how that would make somebody feel agitated and anxious, and how that can lead to self-harm. So obviously, in working with borderline adolescents, that's the aspect of a mentalization failure that we try to address. Okay, so these are just interesting findings. We know that interpersonal distress is linked with suicidal ideation, but in this study, it's very interesting. The pathway is through perceived burdensomeness. And similarly, the pathway from childhood abuse to suicidal ideation goes through perceived burdensomeness. So again, this is a study where the thought of the young person about the mind of the other, and if their thought about the mind of the other is of a negative kind, that person is burdened by my distress, that is the thing that creates this sense of hopelessness within them. So we see more and more how our perception of the mind of the other is very, very crucial. Just like in the hypermentalization, the girl's perception of the mind of the teacher is the thing that triggered her desire to harm herself. So how does mentalization develop? I'm going to really rush through this because I just want to say something about the alien self at the end of that. So in the model of how mentalization developed, and this is not new, everybody here would know what I'm talking about. And people would say, but that's very much like Beyond and very much like Winnicott. Yes, it is. But it's just described in a different language. So when babies are born, they're not able to make sense of emotions themselves, so the mother tunes into the baby, and the mother uses her mind to form a representation of the baby's mental state, yeah? So the mother uses her mind to form a representation of what goes on for the baby. And with that representation, she then approaches the baby and behaves towards the baby. So people call that mirroring. And I don't think that refers just to she mirrors the baby state with her face. I think she does it with her demeanor, with her voice, with her actions, with everything. And the baby then takes that into themselves. They internalize that representation from the mom, and it becomes the building blocks of the psychological self. Yeah, you see that? Now, what happens if that goes wrong? Sorry, this is when it goes right. I'll just quickly go through that. So, the baby has a feeling. The mother forms a representation in her mind, and the baby internalizes that, and it starts the building blocks of the core psychological self. Now, the good enough mother, you want to guess how many times she gets it right? How many times she's in tune with the baby? 30%. Peter Fonicki said his mother was in touch with him 50% of the time. That's probably true. So, 70% of the time, the mother gets it wrong. Us as therapists and people who work with patients, don't think for a second you're always in touch with your patient. Yeah, you're not. Forget it. A lot of the time, one is not in touch with your children and you're not in touch with your patients. That's not the end of the world. The point is to pick it up when you're not in touch and to repair. That's the crucial thing. And things go wrong when one doesn't pick up that you've missed something, that you've misunderstood something, and when you don't repair, that's when things go wrong. But getting it wrong in the first place, that's just normal. Now, when, I don't have that picture, so sorry, I'm going to go back. So if the mother, you see, for the mother to form a representation about the baby, if the mother is a bit like that I described, where she's flooded by her own internal state, she might misread the cue that come from the baby at that point. So say she's got a very critical internal figure in her mind, and the baby is crying, and this internal figure makes her feel like a useless mother, like a bad mother, and she starts to feel really bad about herself. She might feel attacked by the cry. She might get angry about the cry. So she might respond to the baby with anger. So what will the baby take back into itself? The baby will take back into itself, I'm attacking. When in fact the baby might be lonely. Do you see what I mean? So the original feeling of the baby, this is not working now, but that original feeling in the baby is one of loneliness. But what the baby brings back into itself is, I am attacking. So it's completely alien to the true original feeling. Now, that is what Peter and Antonian, who wrote this model, call the alien self. Now, what does the alien self feel like? For our patients, the alien self feels like a constant, chronic, internal object attacking them. I think the anal. That's very funny Freudian slip. The alien self is like that whirlpool that I described. When the alien self is active in somebody's mind, it is that state of utter self-hatred. And you've all seen patients like that, gripped by self-hatred and unable to tolerate anything good about themselves being said. Now, because we've all had 70% non-attunement as we grew up, why doesn't this happen to all of us? The thing is, to some degree it does. All of us have moments where we feel acutely bad about ourselves, yeah? You wake up in the morning and you feel really bad. You think, oh my God, I look terrible, or oh my God, I'm an idiot. So we all have the ability to step into that feeling of being very, very unhappy with ourselves. But we can step out of it and we can think, well, I think that's just how I feel now. It will get better later. Or maybe that's not how other people see me, that's just how I see myself. So we have the ability to step out and maintain a balance. Whereas young people can't, and then they're really gripped by that negative state and there's no escape for them from that negative state. So a bit of a mentalizing model of self-harm. So in somebody, I forgot to say this, I think it comes on the next slide actually. All of us loses our ability to mentalize. Mentalization is not like your surname, you can do it or you can't do it. There are times where we can mentalize. There are times when our patients can mentalize, and there are times where we can't. Mentalization is something that goes on off, on off, on off, on off. And you lose your ability to mentalize when there's a high state of arousal. Now, because of the amygdala in adolescence, there's often a high state of arousal. So they lose their ability to mentalize quite quickly and quite rapidly and quite frequently. But all of us lose our ability to mentalize. You just need to work in an inpatient unit to know that. Or you need to be a parent of children to know that. You know, there are just moments where you are overwhelmed with your own feelings and you lose your ability to mentalize. So what happens if somebody loses their ability to mentalize? Then that thing that relationships make sense, that thing that we understand other people, that thing that we have sense of our own role in how other people feel, that all goes out of the window. And for many patients, they then fall prey for the alien self to take over. So somebody might feel like this patient that I described, the teacher didn't greet her. Now that lasted maybe a second, the knowledge of my teacher didn't greet me. The next minute, she was overwhelmed with feelings of I hate myself, I'm stupid, I'm worthless, I want to cut myself. Do you see what I mean? The alien self comes over and that then becomes the feeling state. And the thing that triggered it, we sort of move away from that. And that feeling is very unbearable where the alien self is present. And then people desperately need to get away from that. And hence they turn to self-harm. I've spoken about that. Now I'm going to literally run through the research that we've done. This is a randomized controlled trial, which we've done in 2012. Actually, this was the first study where efficacy has been proven for self-harm over treatment as usual. Since then, there's been the DBT study and the CBT study. But we took 80 young people and allocated them to MBT group or a treatment as usual. And treatment as usual was CAMT, tier 3 treatment, so it wasn't waiting list management. I'm just going to run through it quickly. So the MBT treatment lasted for 12 months. And we followed both groups up. And as you can see, both groups got better till 3 months. But then by the end, the MBT group had less self-harm, significantly less self-harm than the treatment as usual group. The MBT group also did better in terms of depression than the treatment as usual group. The MBT group showed an improvement in borderline features, more so than the treatment as usual group. Interestingly, the MBT group improved in mentalization and the treatment as usual group didn't. And the MBT group improved in terms of attachment avoidance. And when Peter Fonagy controlled for the attachment avoidance and for the improvement in mentalization, the difference between the two groups went away. Now what that means is the MBT group did better than the treatment as usual group because it improved people's mentalization and because people became less avoidant in their relationships. I think, this is my take on it, it's a bit like, I think we made the alien self in these kids a bit better, because if I'm dominated by an alien self, I'm gonna push you away. Because I'm going to be avoidant in my attachment relationships because you're going to hurt me. You see what I mean? But as one gets more accurate in accurately portraying the mind of the other, one can become less suspicious of other people and hence allow closer relationships with other people and hence need to harm yourself less. So it's quite interesting that those factors have been identified as the curative factors in the intervention. And at 18 months, this is 6 months after the treatment stopped, it just continues. The risk gets less in the MBT group, self-harm continues to get better in both groups, I have to say, not just the MBT group, but the difference between the two groups remains significant, with the MBT group doing better than the other group. All right, we've got 5 minutes left. So Just wondering, I mean, I'm not going to be able to teach you an entire therapy model in 5 minutes, but I can give you sort of an overview. Really, the principle of MBT is we believe people have difficulties in relationships and in families because of their inability to accurately portray the minds of the others. So that's what we try and do in MBT. We just try and kickstart mentalization again and again and again. And we make use of individual mentalization-based treatment plus family mentalization-based treatment, and sometimes we add group treatment to that. And there's a whole structure to it, which I'm not going to go into. But I've developed an app. I'm not sure I'm going to have time to go through the app. I was going to connect it to my phone to show you. But every young person that I see with self-harm, this is part of their crisis plan. So even if I see them for the first session, they leave the first session with this app in their pocket. And the app has a host of resources in the app. Actually, shall we just do it quickly?
I'm sure we could manage.
Okay. Okay, just give me a second. Okay, so that's what the app looks like. And it has these options that people can choose from. And I'm sorry to say this is not just MBT. I put everything in the pot that works when I want to help people. So this brings in DBT very strongly. So the top button that people can go onto is the tip skills from DBT. So they can press on any of those things and it changes and it tells them what to do. So I go through that with them. And I explain to them that these techniques are there to help change their heart rate, and that gives them the same satisfaction as cutting. And then we discuss it in detail. And the progressive muscle relaxation one actually has a little tape. And I sometimes send letters to schools to ask the school to allow the child access to their phone and headphones, so that if they feel distress in the classroom, they can go and sit quietly, put their headphones on and listen to this, just to help them calm down. And then the next button is the distract me button, where they can, if they feel panicky, they can go into that. And then that button is sort of bringing in mindfulness, but that one, look for emotions, brings in some MBT skills, and I go through that with them to just help them pause, stop, think, what am I feeling, what is the other person feeling, am I making assumptions about the mind of somebody else? So just to help them pause and stop. And then there's a whole section on mindfulness with tapes that people can listen to. And then there's a section on Soothe Me, where they use their senses to calm them down, and they can personalize it. Under hearing, they can upload music, their own music, to help them. And under vision, they can tap there and tap on the plus, and they can connect it to photos and calming images and some nice memories and so on. And then there are meditation tapes at the end that they can listen to, which I also say that they can listen to that at school if they need to. Thank you. So the thing is just, it gives somebody something in their pocket. I used to give people handouts, my patients, and then I realized that is so old-fashioned. They need something in their pocket that they can use when they need to. And I've had a patient who hasn't self-harmed for over 6 months because she just used the app, so it is a little bit helpful. And then there's a crisis plan that I give to parents as well. I mean, this will be in the handouts. I'm not going to read through the crisis plan with you, but it will be in your handout that you will get. What is our role? I mean, really, the thing is, these kids live in a very, very dehumanizing world. You would see this. When they speak about themselves and their hatred for themselves, they speak about themselves with such disdain, such hatred, such dehumanization. I think we need to embody humanization. We need to be very real in our interaction with them. We need to be authentic, real, interested, curious in them, supportive of them, and really help with warmth and compassion. so that they have a different experience, so that they can try and form a picture of who they are in our minds. And again, just be curious about mental states and try and help them develop a curiosity about mental states. And I do that a lot. I use a lot of drawings and say, okay, so this is your boyfriend. Let's draw a thought bubble above his head. And this is you. Let's draw a thought bubble above your head. What do you think is going on in his head? What do you think he's feeling when he does this, when he doesn't return your call or whatever? So, to open that up. And really what we want to do is we want to increase their ability to mentalize. Because the more somebody's able to accurately portray the mind of the other, the more they will not become over-roused. So really, the last point is we need to help these kids find humanity about themselves. Thinking about the talk this morning about the pain threshold, we need to help these kids find who they really are and find humanity about themselves, and find care and compassion about themselves. Then they would become aware of pain threshold and those sorts of things. We need to help them find a sense of hope. So often when we see these kids, they have what I call developmental arrest. They're not able to go to school, they're not able to go out, they're not seeing friends, they're just spending time at home on video games and stuff. And really, if we think about the developmental trajectory of adolescence, it is a phase of forming an identity, forming a social network, finding oneself in your social network, being able to manage school. I mean, our task is to help these kids back onto the developmental trajectory. It's only when they get back onto the developmental trajectory that they will feel a sense of mastery and a sense of achievement. And until then, they will feel like a failure. And so often, adolescents that I see speak about feeling such a deep sense of failure. And our task is really to do whatever we can to try and help them find that in themselves that they can connect to, that feel strong, and that can connect them to their passion and to their desire to move forward in life. But sometimes we need to help them with practical things. Sometimes they do need somebody to go to school with them, like a healthcare assistant or an OT, or an arrangement with a teacher who meets them and walks to school with them, or a parent who helps them to school, or an arrangement with a school that they only attend for an hour a day for a week, and then one step it up. You see what I mean? Sometimes one has to practically help these kids and not just therapeutically. And really, the more we can help them to accurately portray the minds of others, the more they will be more able to be less frightened of the world around them, and more able to see themselves for who they are and not through the eyes of the alien self. Thank you very much.
To be part of the advancement of child and adolescent mental health, visit www.acamh.org.